Atypical antipsychotics for acute bipolar depression. Here is my declaration of interest. I have no conflict of interest or anything to disclose in conjunction with the present work. We know that the treatment of bipolar depression is less investigated than the treatment of unipolar depression. And this is compelling considering that historically, most of the trials were just spotting and focusing at the current major depressive episode, no matter if this was part of the course of unipolar or bipolar disorder, major depressive disorder or bipolar disorder. And this is an issue because historically the approach was to treat the major depressive episode in the same way, no matter what the underlying course of illness. And this is one of the main reasons why people is usually, most clinicians are still quite comfortable in prescribing antidepressant monotherapy, even for major depressive episodes associated with bipolar disorder. Even if this is a practice that is not supported by the international treatment guidelines. There's also uncertainty for the construct of bipolar disorder, and especially BD2, and this is one of the reasons why there's a less confidence for some clinicians in the prescription of a different treatment for bipolar disorders compared to unipolar depression. The antidepressants are not just, controversial from a safety standpoint because they may lead to treatment emergence, affective switch, increase the risk for suicidality, or they may induce rapid cyclicity, especially at least in monotherapy, but they are also not even effective in the treatment of acute bipolar depression, not even in the maintenance treatment of BD as monotherapy. One of the issues here is that people with bipolar disorder do spend most of their time, the lifetime, with depression rather than mania, hypomania, or even euthymia. And this is why most of them have a predominant polarity of depression, especially in BD2. Well, predominant polarity is a concept that is very clinically intriguing, but has also some shortcomings. But for now, what it matters for this presentation is that people with bipolar disorder do endorse depression much more frequently than mania or hypomania. And this is also why they may be misdiagnosed as unipolar cases and then exposed to antidepressant monotherapy. This is a trend, an utilization trend for different medications from Rhee et al. This is a recent survey apprised in the American Journal of Psychiatry in the year 2021. As you can see, there's a huge increase in the utilization of the second generation antipsychotics compared to the late 90s. And there's a sharp reduction in the utilization of the mood stabilizers, including lithium, which is compelling, especially considering that lithium is the sole mood stabilizer that is effective as an anti-suicidal drug. The antidepressants, as monotherapy, are also much more frequently prescribed than before, and this is also a matter of controversy from a clinical standpoint. What are the treatments? Well, the second generation antipsychotic treatments approved for the treatment of acute bipolar depression in adults. Cariprazine is a quite interesting drug which is approved for the treatment of acute bipolar depression associated with type 1 BD. Lumateperone is the one that is approved for the treatment of both type 1 and type 2 acute bipolar depression. The starting dose is also the same of the target dose and can be prescribed either as monotherapy or an adjunctive therapy with lithium or valproate. Lurasidone is approved for depression associated with type 1 BD, and again can be prescribed as monotherapy or adjunctive therapy. It is also quite effective in the treatment of major depressive disorder with mixed features, by the way, but this is an off-label prescription. OFC, so olanzapine fluoxetine combination, is approved for the treatment of bipolar depression associated with type 1 bipolar disorder, and is also approved for the treatment of mania and mixed states as monotherapy, depending on the ratio of fluoxetine and the olanzapine. Quetiapine is approved for bipolar depression, and the dose for mania and mixed states is almost twice the dose for bipolar depression. There's also empiric support as an augmentation with standard antidepressants for major depressive disorder, treatment-resistant cases. What about lumateperone? Lumateperone is a quite interesting drug because it concurrently modulates serotonin, dopamine, and glutamate. It is much more potent as an antagonist of the 5-HT2A serotonin receptor than the T2 receptor. The higher the ratio of 5-HT2A and dopamine D2 antagonist, the lower the propensity for extrapyramidal symptoms. This is particularly true for drugs like, for example, clozapine. But this is also a rule because there are other issues that may be responsible for the propensity of the drug in inducing extrapyramidal symptoms or not inducing such kind of adverse effects. So what about lumateperone? This is also interesting because the clinical profile of the drug changes depending on the dose. As the dose increases, it acts as dopamine D2 receptor and presynaptic partial agonist and postsynaptic antagonist, which is more selective for the mesolimbic and mesocortical pathways. In addition, lumateperone is also an inhibitor of the serotonin transporter and is also able to increase the phosphorylation of the NMDA glutamate receptors, type 2B, in the mesolimbic pathway. So this drug may theoretically enhance sleep or reduce the agitation or regression at lower dose and exert some sort of antidepressant efficacy at higher doses. Most interesting, the drug has a very low propensity for cardiac abnormalities and has a placebo-like profile in terms of weight gain and motor disturbances. Cariprazine. Cariprazine is D2 receptor partial agonist, but is also a strong preferring D3 receptor partial agonist. Blockade of the D3 receptor may explain the putative procognitive and antidepressant effects of the drug, but what is most interesting about cariprazine is the pharmacokinetics, because the parent drug has two main metabolites, which are desmethylcariprazine and D-desmethylcariprazine, with the latter being responsible for the very long half-life, which allows for a steady state to be reached after 1 or up to 3 weeks. Common side effects include extrapyramidal symptoms, akathisia, but the good thing is that having such a long half-life, if you miss one dose, there's no issue about rebound of psychosis. On the other side of the coin, there's also the higher propensity for prolonged duration of the hypothetical adverse events. Lurasidone is as strong as a potent 5-HT7 receptor antagonist coupled with 5-H1A partial agonist that could be theoretically explain its putative procognitive effects and antidepressants effect. There's low propensity to induce anticholinergic side effects or weight gain or hypotension, but still lurasidone can induce akathisia or nausea, and this is also why, and one of the reasons the drug is usually prescribed at night, and it must be taken with at least 350 kilocalories of meal because of its potent, considerable binding with the proteins. So, what are the randomized clinical trials of second-generation antipsychotics monotherapy in the acute treatment of bipolar depression. Here you have a picture. I'm not going to read all of them. This is just for your reference. What it matters here is that 2 out of 3 trials are positive at current time, at writing time. So, what are the second generation for acute bipolar depression in those, and how do they work against each other? This is from a network meta-analysis involving 18 monotherapy, and this is the way you should read this table, which is a league map by the league table, by the way. So the MADRS results for efficacy in terms of reduction of the MADRS score from the baseline actually to the endpoint against the baseline are on the top right side of the map. And you see, for example, that lurasidone against placebo leads to a reduction of the MADRS total score of 4.71. This is the credible interval. Well, on the lower side of the league map, and the left side, you see there's the bottom left, sorry, there's the response, and this is presented in terms of odds ratio. So, for example, lurasidone against placebo has a 2.58 also of higher response propensity compared to placebo. So you will be able to stop the presentation and check any comparison. And the bold ones are the statistically significant ones. Again, here is the same, but this is just presented in terms of odds ratio because they are binary outcomes. And above you see acceptability, discontinuation due to any cause, against the discontinuation due to adverse events at the bottom left, which is tolerability. Again, bold is for significant results, and this is the same kind of league table as the previous one. This is the SUCRAT, so the surface under the cumulative ranking curve. This is a treatment hierarchy that is obtained by ordering the effects of the least effective or tolerable versus placebo. I'm going to include this for your reference, but I think that the most reliable for the clinical interpretation is the previous kind of table, so the league table. So there are also other network meta-analyses that aim at comparing and controlling for considering different pharmacotherapies for the acute treatment of bipolar disorder, not just the second-generation antipsychotics. And this was intended as a network meta-analysis. However, the authors, as far as I could retrieve, I was able to retrieve just the pairwise direct comparisons against placebo. And so this is the one that I'm going to present here. Interesting fluoxetine monotherapy has higher odds, and this is significant, by the way, because this is no crossing of the null value 1. So the y-axis here, and it is more effective than placebo in the acute treatment of bipolar depression according to the pooled trials here. On the other side, olanzapine monotherapy is also significantly more effective, not as effective as fluoxetine monotherapy. And even if we are going to focus on the second-generation antipsychotics, I found quite intriguing to remark these kind of results. This is about tolerability, so dropouts due to adverse events, and here you see that quetiapine and aripiprazole are probably, actually not probably, are just the only two comparisons that are significant because they do not cross the null value 1, and you see that both of them are less favorable than placebo for this kind of outcome. What are the risk ratio for response? This is another network meta-analysis. In this case, there are included 69 trials, but these are adjunctive trials. still, I was just able to try the direct comparisons against placebo. Anyway, so consistently with the previous one, we see that fluoxetine monotherapy is more effective than placebo in leading to achieving response. And also for fluoxetine monotherapy was statistically significant, it looks like. Let's see what the credible intervals say. Yes, it's 1.02, so for a very low margin, it is not crossing the null value. It's more effective than placebo for completion. Anyway, let's go back to the second generation antipsychotics. And now we are presenting the data for people for pediatric bipolar depression, so people aged 10 to 18 years old. The average trial duration was 6 to 8 weeks. We have 4 trials only, and we know that lurasidone and olanzapine fluoxetine are the second generation antipsychotics approved for the treatment of acute bipolar depression associated with type 1 bipolar disorder in children or adolescents. Obviously, olanzapine is the second generation and fluoxetine is the SSRI antidepressant drug. So here you see, well, actually you can see, I do not pretend this to be easy to read, but anyway, it's just for your records. There are which denotes a significant association. So, for example, here you have lurasidone, olanzapine fluoxetine combination, so OFC, that is more that is associated with higher efficacy compared against placebo. But again, this is unsurprising that there are also much higher odds of side effects in terms of cholesterol, metabolic outcomes compared with placebo. So this kind of profile, both efficacy and safety and tolerability profile, is definitely consistent with what we found for the adults with acute bipolar depression. So what the take-home message here is, so here is just the big picture. I did not present you with the specific trials, so the approval, the registration trials for the main second generation antipsychotics submitted to the FDA. And this was not presented for brevity issues. But still, I strongly encourage you to go back to the original trials for more additional details. The other point here is that the second generation antipsychotics are quite popular treatment for acute bipolar depression, and so you should be confident about what it is supported by the evidence and what is not, and also about the different safety and tolerability profile of different drugs beyond the efficacy profile. So the second generation antipsychotics are even atypical against each other, so they do change very significantly against each other. Another issue is that the use of second generation should not occur at the expense of lithium. And this is what we may perceive from the re-study, the survey about the utilization trend in the patient facilities in the US. We need more additional studies for pediatric BD.